Karunapuzha, Dr. K, completed his internship in internal medicine, residency in adult neurology, and a fellowship in movement disorders at the University of Texas Southwestern Medical Center in Dallas. Dr. K is a keen clinical educator who has received several teaching awards and is a frequently invited speaker not only in Oklahoma, but across the country, also training other neurologists in best practices and in the use of new treatments. Dr. K is at the Meinders Center for Movement Disorders at Mercy in Oklahoma City. So, Dr. K, we're looking forward to your presentation tonight. And I think, does everything look set on your end, Doc?
Yes, indeed.
Okay, great. Well, I'm going to turn it over to you. And again, if you have questions along the way, please just plug those into the chat box, and we'll handle those as best we can towards the end. All right, Dr. K.
All right, everyone. Thank you for joining today. As I said, with our inaugural one as well, this is troubling times that we are in. This year's been a hard year for all of us for various reasons. And while we would love to do these as live sessions, have everybody together, congregate and learn more about this disorder, I think we're in a way blessed as well that we have this sort of technology to learn more about the disease, to visit with your physician or your nurse practitioner, even on a telemedicine format. So having all of this is a blessing in disguise. I'm glad you're all here today to learn about one particular disabling problem of Parkinson's, called Parkinson's disease psychosis. To give you a primer on what Parkinson's disease is, it's a degenerative disease of your brain. It's breaking down circuits in your brain one by one, slowly spreading from one particular circuit all the way across your brain. It is second only to Alzheimer's as being an extremely common disorder in an elderly patient. We're talking about 1 million odd patients currently in the US with Parkinson's. The most common physical symptoms are listed in 1, 2, 3, 4. First being shaking or tremor. Your hands are at rest or your leg is at rest and will start to shake. Second is slowness or akinesia is what we call it, where it's hard for you to move fast. Everything is in slow motion. You're doing everything in slow motion. Number 3 is stiffness or rigidity. And number 4 is instability or trouble with balance. Most of these symptoms start on one side of your body and gradually makes its way to other body parts. So it could be in your left arm or your right leg and slowly making its way across years. We're talking about 10, 15, 20 odd years with this disease. But along the way, you also start to hit non-physical circuits in your brain as well. The stuff which controls other things like your mood, your sleep, your ability to swallow, your ability to do automatic things, for example, bowel movements, bladder, blood pressure, eventually thinking, and also your hallucination circuits. And that's the topic of our discussion today. We're talking about a disorder within the Parkinson's spectrum, which happens in about 50% of Parkinson's patients at some point during their life with this disease. So think about it. Half of patients who have Parkinson's will develop hallucinations and or delusions at some point during the course of their disease. So that is something you have to pause for a second and think about, going, this is not something which is rare. This is not something which won't happen to me. This is not something that I see it's happening in Joe, but the rest of us, we're all okay right now. I'm glad we dodged a bullet here. It's about a 50% chance. And it can happen at multiple stages during the course of your disease. To give it definitions, hallucinations is simply perceiving, using your senses, things which are really not there. We're talking about either seeing things, hearing things, feeling things, smelling things, or tasting things which are not there. Your brain just cooked it up. Delusion is a false belief, usually an irrational false belief, believing in things that are not true despite being given evidence to the contrary. And that's a delusion. There you're not seeing things. You're stuck with this notion which you can't shake. But what causes all of these symptoms in Parkinson's? You can bucket that into two categories: internal causes and external causes. Internal causes are all the things which happen within your body which enhances or brings out psychosis. First being progression of the Parkinson's itself, which means as that circuit is slowly getting damaged and it's slowly spreading from the movement or motor circuit to other circuits in your brain, it can hit that hallucination circuits as well. And so your natural disease progression with this disease itself causes hallucinations and delusions. But then there are other things as well. For example, changes in vision. So if you have cataracts, if your retina is slowly getting damaged for whatever reason, various factors concerning your vision can make you prone to illusions. Things along the edges of your vision, stuff will start to play about, which makes you think, oh no, did I catch something moving? Or is there something on the ground? Is that a mouse? Oh wait, that's just a ball of sock. And so you start to misperceive things when your vision's already impaired. And this is exactly why it's not always the Parkinson's damaging it. It's also other things going along with your body, which you're losing warranty on, which gives you that added component of hallucinations. What about other things? Dehydration, infections, like urinary tract infection or a pneumonia or a chest infection. All of these guys can precipitate or amplify hallucinations in you, which means you're having a latent or very minimal hallucinations kind of in you, which you may not be recognizing yourself, but it's brought to light when you're going through an infection. Why is that? Because many times when you're having an infection, and we've all gone through this, where let's say you're dealing with a bad cold or a flu. Yes, you're still able to function and operate, but you feel foggy, you're not fully there, you forget things for a couple of days and then it comes back. That's because it's depressing your ability to think clearly. In Parkinson's patients where it's damaging these sort of circuits, you're already on your last leg in terms of having few nerves left which are operating and helping you think. And so even a little bit of infection pulls you down to the point where you manifest a lot of these hallucinations. It's sort of a red flag. If you start hallucinating during your infections, then we know it's down the road, it's coming. The hallucinations are going to happen even without the infection. Other scenarios, like where you are given lots of sedatives or anesthesia. So think about admissions to the hospital where you have an elective admission for a knee surgery. And at that time, you get anesthesia or pain meds or sedative meds. And as you start to wake up, you're goofy, you're confused, you start to hallucinate, get belligerent. Why? Again, the same thing. Those medicines have a depressive effect on your thinking. And finally, dehydration. Your electrolyte levels, your salt levels in your blood fluctuates and can cause similar confusion as well. So the summer months can be hard for a lot of patients. What about external causes? Things on the outside in your environment which can affect you. The medication which you take for Parkinson's itself can be problematic. Why? The mainstay of treatment in Parkinson's is dopamine-based drugs. Anything which can either give you dopamine itself, like your carbidopa, levodopa, or medicines which trigger dopamine receptors in your brain, like dopamine agonists, or other medications which can mimic certain other circuitry into firing, like anticholinergic meds. These are all medications which help you move, do things correctly in terms of mobility, but can also trigger other circuits in your brain into misfiring and doing the wrong things. For especially so, dopamine is a double-edged sword. So especially in the initial stages, you do well. You can take enough of dopamine medications and you do just fine. But as these circuits, other non-physical circuits start to get damaged, you start to get impact from that dopamine itself going into other circuits, like your blood pressure might drop, you might get sleepy, you might get compulsive behavior, and it can trigger or worsen hallucinations. Same thing goes not just for dopamine or your Parkinson's meds, also other things like alcohol or recreational drugs can have a negative impact on you. I mean, in Oklahoma, we just legalized medical marijuana, and this is something we see often where people want to try it just to see if it has any positive impact on them, and many times we get calls back saying the person was goofy or seeing things after they took medical marijuana. Final one you see on that list, dim lighting or the time of the day. This kind of goes into that vision changes we talked about, where as you get towards the end of the day, the middle to the end of the day where there's less bright lighting, your eye is not able to discern all the different shades, the contrast and things like that. So you're more prone to illusions if everything is more dim and dark. This is why we always tell patients who are experiencing hallucinations, especially in the evening or nighttime, make sure there's bright lighting, especially when you're awake. Or if you're asleep, make sure there's lighting in the hallway, which is bright, because when you get up and go pee, you don't want you reflexively jumping away because you thought you saw something in the shadows. All right. So who all are at risk? First, older age, meaning people who are elderly with Parkinson's are at a higher risk. Duration of Parkinson's, the longer you've had Parkinson's, meaning more it has chance to damage all those circuits, the higher the risk. The more severe form of Parkinson's, if you look very severe in your Parkinson's, you're at a higher risk. And if you're on a lot of Parkinson's medications, it can also have that impact, just like we talked about, where dopamine and other similar drugs can have a negative impact. In terms of what we think is actually going on in the brain, as to what creates or triggers hallucinations, we think of two new neurotransmitters. One being dopamine, second being serotonin. Dopamine, like we talked about, is a major neurotransmitter or chemical those motor circuits need to function. But they too can trigger in the hallucination circuit and amplify and cause hallucinations. But it's not just dopamine. We also think serotonin, another neurochemical or neurotransmitter, has a major role in hallucinations and delusions, especially so in Parkinson's. And with that being said, how does this evolve across time? In the early stages, you have illusions. It's not even full-fledged hallucinations, illusion, where you're misperceiving something which is already there in your environment. Like I made an example before, like, you could have a sock which is on the ground just along the corner of your eye, which you catch at the edge of your vision, and you think that's a mouse or a rat sitting there on the ground. And you have to turn and look, and you go, oh, that's just a sock. So you're misperceiving things. That's an illusion. When you're cooking things up in your mind and seeing things which other people don't see, that's the hallucination. And how does that initially happen, the hallucinations? It's very vague. It's vague shadows just along the edges of your vision, just on the corner or periphery of your vision, or something like a shadow darting by real quick along the edge of your vision or under you, and you're like, huh, did just something move by, or was somebody just standing there? This is one of the earliest signs of visual hallucinations. And that is what we call fleeting shadows of passage phenomenon, meaning something seems to be moving by. You also start to get a false sense of presence, where you start to feel like it's almost like there's somebody standing right there behind you. You're watching TV and you just feel like maybe your wife or somebody standing right there. And you just have to look. Or you get the feeling there's somebody in the room with you, or there's somebody in the next room, and you say, honey, can you go and check? I think there's somebody in the next room. This sort of sensation of a false sense of presence of somebody in your room, this is also an early sign. Some of the other scenarios which can happen along with the early symptoms is you maintain insight. And that's an important thing to understand, is that insight is their ability to discern that this is not real. That what I'm seeing along the edge of my vision is not real. Or after a couple of times of misperceiving that thing on the floor as an animal or as a rat, you kind of start ignoring it because you know it's not real. How can it be always there's a mouse or a rat in my floor? That's not possible. So you have enough ability to kind of counter that and say this is not real. That's insight, and it's usually retained. But as you progress through the disease, you start to lose that insight, where you don't know it's not real anymore. What happens there? You start interacting with these hallucinations. You might be seeing an animal or a little person, and you might be interacting with them, trying to speak to them or look at them carefully, try to interact or touch them. Other people might see you doing this. These are the sort of scenarios which many times happen. And it is usually during that stretch when you lose insight is when complex hallucinations come about, much more than just vague movements, like really bizarre things start to come about. And it's also during that stretch, typically, when you start to get delusions. What time frame are we talking about here? Symptom progression usually occurs over a course of 2-3 years. We're going from mild to severe. But this can vary from each individual to where it can be very shortly, very quickly, it can amplify and get bad, or it can stay mild for years on. And the only thing which we can't predict is the things which usually amplify or worsen it. Like we talked about, infections, dehydration. I don't know when you're going to get dehydrated next time. I do not know when you're going to get the flu or bronchitis or urinary tract infection the next time. So you might be having mild hallucinations which you're poo-pooing away, going, it's not too bad. But you don't know when you're going to get that worsening of hallucinations because you can't predict these things like infections. This is why many times we're aggressive and we like to nip it in the bud. To talk about a little bit about how these hallucinations manifest, we talked about how the visual hallucinations can manifest in the early stages, like shadows and then full form people, usually small animals, kids, a couple of people, not necessarily scary, but this is how it can happen. Some people perceive it mostly at night in the dark. When they wake up, they feel like there's a face standing next to them, or in the corner in the dark, there's a person, almost like an image of a person forming, and then it disappears. These are the different ways we get visual hallucinations. Sometimes it's not even people, it's just lines and objects, kind of like the lines on the floor, your carpet lines are just lifting off and then coming down. And that's how many times you catch other forms of visual hallucinations. Other things happen too, like touch, or we call them tactile hallucinations, where you feel like there's lint or thread or hair on your skin and you're constantly trying to pull things off, or you feel like creepy crawlies, like ants or bugs are on you, and you're just wiping and constantly moving things away. So you're constantly under that notion that there's something on your skin. It can be on your scalp, it can be on your hands, and you might end up collecting a lot of this lint and dust, trying to show people, like, do you see it, the bugs and things like that. So it can get pretty bad. Hearing, it's usually mild stuff. You don't hear a lot of voices and stuff. It's usually vaguely music being played in the background. You might get that sensation. Or sometimes birds chirping, other times vaguely somebody's calling out your name. Just, very mild voice, you hear somebody saying, your name. And you're like, did you call me? And this is many times a very subtle auditory or hearing hallucinations. Taste and smell. As you guys are very well aware of, Parkinson's patients lose their sense of smell and taste. Over years, it goes away. And all of a sudden, now you start to taste things, and it's bizarre taste, or smell things like burnt smells or a dead rat, and you're constantly trying to find it. There must be something dead here in the house. So these are the different ways in which hallucinations can manifest. What about delusions? The false belief which you cannot shake despite being given evidence to the contrary. One is persecution delusions, meaning you feel like you're paranoid. You're paranoid about people around you, that they're ganging up on you, they're plotting to do stuff to you. Your home nurse is stealing stuff from you. Your neighbor is up to no good. Or your own kids are trying to plot and get you into a nursing home. Why are you saying all these things to Dr. K in the clinic? Or why are you complaining about my symptoms? What's your agenda? These are the things, they start to get real suspicious. So that can kind of seep in very gradually. And many times with Parkinson's, you get depressed or irritable. So a lot of people misconstrue this paranoia as this person is just being irritable and just angry and pissed about certain things that you do. You don't realize this is just the beginnings of a paranoid delusion. Other flavors of this is jealousy. You start to suspect your partner of 40 years that they're up to no good, that they're cheating on you. Or it can be in reference to another person, like they can think their kids are up to no good, and they come and walking in and telling me that, I thought I raised him right, but I think he's cheating on his wife. So things like this can happen. Reference delusions is not common, but you see this too, whereby you kind of introduce yourself into other scenarios which have got nothing to do with you. You feel like you're part of that. Like common things being, let's say on TV, you're watching something on TV, and you somehow feel you're part of that whole process. And so you turn and you talk to somebody and say, I didn't make that legislation. I think that was him, and so I didn't sign off on that. And everybody's looking at you going, what are you talking about? So things like that, where you reference yourself into other scenarios. So why bother treating this, especially if it is mild, not intrusive? You have insight, this is not real. Why do you care about treating it that early? I get it, when it's real severe, when it's bad, yes, I would like to be lucid and not see these things, fair enough. Or we would like our loved one to not have these severe hallucinations or delusions where they're accusing you. I get it that we want to treat people there. But why do you want to treat it at the early stages? It accounts for nearly 25% of all hospitalizations that Parkinson's patients face. What does that mean? Hallucinations, falls, infections like pneumonia, urinary tract infections. These are three major things which get you into the hospital. Why do we care about hospitalizations in Parkinson's? Because every time a Parkinson's patient gets hospitalized, even if it's for an elective procedure, like whatever, cataracts, knee surgery, they're lying in a bed for several days at a stretch, and they're not using a certain set of muscles. Their back muscles, their leg muscles, and those muscles, when they're not used, they get paper thin. It's called deconditioning. So when you finally come out of the hospital, your physical, your motor symptoms have taken a stepwise decline. So a couple of times you keep getting admitted like that, you're going to keep going downhill way faster than you would have naturally gone with Parkinson's. This is why it's extra crucial to avoid hospitalizations as best as we can and push it to the lag end of the disease, which it's inevitably going to happen, but we're going to try to push it as far as we can to the lag end of the disease. This is extra crucial, and hallucinations is one of the treatable things which we can do from that regards. And this is why we want to nip hallucinations early and not wait for it to get real severe and then you're hospitalized and then you try to correct this problem. We also know statistically that your care partners, the people taking or helping you with your Parkinson's, have a decreased quality of life when you're suffering through bad hallucinations and delusions. So how do you manage to treat it? How do you recognize that it's mild, it's there? What are your approaches to treatment? First thing, we make sure it's not being triggered or amplified by other instigators, like you're not dehydrating, you're not having an infection. These are things we look for, screen for, and treat if need be. Number two, there are certain psychological techniques we can send you for psychology or psychotherapy to manage the mild ones using certain techniques they teach you. Number three, we can adjust your medications. For example, we can dial down a little bit of your dopamine medication so that it's not flaring up your hallucinations as much. Now understand there's a limit to how much you can dial down your dopamine medicines, because after a point you're going to slow down physically. You need the dopamine to move, but you can't have too much of it because it seems to instigate your hallucinations. So we play around with the medications. There are multiple medicines we can adjust and move to see if we can get rid of the hallucinations. So a major drawback many times is when your hallucinations are beyond just mild stages, it's in the middle or severe stages, there's not enough dopamine you can push down on without running into being extra slow and stiff as a consequence. And so back in the day, before 2016, we had no FDA-approved medications to treat the hallucinations and delusions in Parkinson's disease. And we had to use, when it got bad enough, antipsychotics, which we would give to, let's say, schizophrenic patients. Problem with these sort of antipsychotics is that not that it didn't work, it worked well to suppress your hallucinations, but at the cost of making your Parkinson's symptoms very severe. And so in 2016, pimavanserin, or it's known by its trade name, Nuplazid, was approved by FDA, and its only indication is to treat Parkinson's disease psychosis, meaning the hallucinations and delusions associated with Parkinson's disease, not any other disorder. And it was made in a way that it manipulates serotonin. Most of the other antipsychotics hit dopamine, and that's why it messes up your speed and your tremor and your stiffness. Nuplazid only manipulates serotonin, and therefore when you add that, you don't get any regression or slowness or stiffness or worsening of your Parkinson's physical symptoms. And you can add Nuplazid without adjusting any of your Parkinson's medications. It's just an add-on. It's a once-a-day medication, no need for titration. It's a single 34 milligrams once a day, any time of the day. But the one thing with Nuplazid is it takes weeks to build into your system. It's not an immediate thing. You take it and tonight, all of a sudden, my hallucinations are better. It takes time to build in. This is another reason why we usually try to be proactive and catch your hallucinations early and then give such a drug so that it takes its time to build in and stop what you're experiencing. Rather than waiting for everything to go downhill and be real bad and you're about to be admitted into the hospital for a bad case of hallucination, no point giving Nuplazid then, because it's going to take another 4 weeks for it to have an impact. I'm sure we can give it, but then we'll have to wait. We still have to get hospitalized. This is why we always screen for this problem and try to aggressively treat it early. And so the importance of you or your loved one reporting these symptoms is extra crucial, because without that information, we can't take the proactive measures that we just talked about. And the one major issue with this particular symptom of Parkinson's is about only 10 to 20% will proactively mention this to their providers or even to their care partners. Why is that? Fear, embarrassment, stigma associated with hallucinations, or, oh, I don't want people to think I'm cuckoo. You know, sometimes when we ask patients or screen for questions and we say, do you see those vague shadows or edges oh yeah, I catch them. Occasionally I see that. Sometimes, you know, and when we ask more questions, yes, I see the person sometimes. And their spouse would be like, how come you've never ever told me about this? And so this is sometimes what they tell you. Well, I was kind of embarrassed. I didn't want people, you know. They're afraid many times, like, of admitting that they're getting a new symptom as well, because that is a sign of disease progression. Internally to them, it's hard to process that they're taking that one step forward in this disease. And then finally, it's also on the provider side, right? Many times doctors, you know, they're so busy trying to manage your motor, your physical symptoms, but the time runs out and you're done with the visit and you're like, okay, next time. And you don't get that opportunity to discuss this, or for them to ask the patient, are you having X or Y non-physical symptom? And so your ideal conversation is understanding about the disease as best as you can. This way, you're aware that these things can happen to you. And when it does happen, you discuss this, make a plan with your partners, number one. Number two, bring it up as early as possible to your healthcare provider. This way they know they can at least notate this in the chart and have this for discussion on the next visit. And describe it as best as you can, what it is that you're experiencing, hearing, sensing, feeling. And there's always a plan which we can set up for you. Educating yourself more about this symptom. This is exactly what you're doing today. And finally, letting your doctor get updates from time to time on what's happening. This way they can track the progression of this and know when to kickstart some of the more fancier options like we just talked about, like Nuplazid. So in summary, more than 50% of Parkinson's patients can develop hallucinations or delusions at some point in their life. Visual hallucinations, seeing kind of hallucinations are the most common kind. They do tend to progress over time. You must open up and give us honest answers to these questions so that we can treat them early and nip it in the bud. And understand that there are many strategies for treating this, including FDA-approved options like Nuplazid. With that, I'll conclude my program today. Thank you so much for being so patient and listening in. I'll take any and all questions at this point.
Dr. K,
Yes.
I think there was one of the first questions that came up, and you kind of mentioned it in towards the beginning of your talk, but maybe just to repeat that, there was a question: does the Parkinson patient recognize the symptoms themselves, or do the family members recognize it in them? So maybe just a little recap on that part.
So initially, you do have insight. You do have insight to what is happening, and you know it's not real, but you're able to capture it. But sometimes it's so subtle, you don't realize that this is a hallucination, right? You catch a vague movement along the edges of your vision and you go, man, that must be my glasses, the new glasses which I got, or must be my cataracts. You explain it in other ways, which you think makes more sense to you. Or you feel like, you know, there's an odd smell or a vaguely somebody's calling your name, and you just think, man, I'm going deaf, and most likely my wife is doing calling me. And so you many times are experiencing it, and until you're told otherwise what it is, you tend to assume that it is something else going on altogether. But once you're told that, then you know you can recognize for it, and you're always keeping an eye out for it. So meaning you do have recognition of it, especially if you're told what it is. But now that you're educated about it, you will instantly recognize when this happens to you. All right. So, do you want to field other questions?
You see the question there, Dr. K, about our itchy spots. Can that be a manifestation of a hallucination, or?
Yes, it can. And so having a sensation of like there's always something there which you have to itch and scratch. And so a lot of people itch or scratch their scalp, their skin till it gets raw, thinking that there's something which bit or there's a rash there which nobody else can see, and they're constantly trying to find it. And they show it to all of us, like, do you see this rash which might be there, and you don't see it. So this happens all the time. It can be a subtle hallucination, but common things being common, always double check it's not a skin condition, right? And so always double check and see if there's a rash. If there's an obvious rash or something welling up, you know what you're dealing with is a skin condition. And that's where your dermatologist comes in.
Is there a good way to know if it's Parkinson's disease psychosis or if it's a side effect of medication? How do you delineate the difference there?
In both scenarios, it's triggering a circuit to malfunction and you're perceiving a symptom. Whether it's the disease damaging that circuit and you're showing that symptom, or a medicine is triggering a circuit and you're showing that symptom, it tells you that there's an underlying gradual damage in that circuit. That's why you're prone to that side effect with this medication. It seems to be bringing out something which is latent, which might brew and manifest a couple of years down the road, but now itself, when you take a certain medicine, it's bringing it to life. Especially in the early stages of Parkinson's, if you are given a medication, even at low dose, it triggers a hallucination. We start to think, is this medication induced? And we can dial down because the timeline matches. I started this medication, and as I inched up on the dose, the very next week onwards, I started to see things. So that timeline gives us that answer on whether this is more of a drug-induced phenomenon or just the Parkinson's disease itself. But sometimes it's a bit of both, right? Like your disease progresses, you're on the same drug, which is a known provoker of hallucinations. It's doing well for you. You've been doing this for now 4 years, and now in the 5th year, you're starting to see hallucinations. That could be because your disease has progressed enough to where it's now sensitive to that medicine. In either scenario, your first step is dialing down some of these offending medicines and seeing if you still have those hallucinations. But timeline is your usual crucial answer if you want to know clear cut if this was a drug-induced phenomenon, not because you start the medication in that next 1-2 weeks, boom, what you didn't have all of a sudden appears. So there was a question, so I'm going to read a couple of questions which are listed here. Is believing a fantasy of others a delusion? Yes, especially so if it's not real or doesn't usually make sense to other people. And you can't escape that belief. Like no matter how you rationalize this, it seems to be stuck in your head that, no, I think this is how it is. That can be a delusion, a false, fixed, usually irrational belief, which you cannot shake despite being given evidence to the contrary. And so I use Nuplacid. What would happen if you stop Nuplacid? Just like most medications in Parkinson's, you are masking the symptoms effectively. So if you stop taking a medication, that circuit will re-manifest its symptom. You're only suppressing that circuit with effective medications. So anytime in Parkinson's you stop a medication, whatever symptom it was controlling just re-manifests. What is the best medication for pain in Parkinson's? Is gabapentin a good choice? Pain in Parkinson's happens for various reasons. In Parkinson's, the disease itself can damage and give you pain syndromes. But more often than not, pain in Parkinson's is usually a mechanical issue because you're stooping, you're bending, you're shuffling, you're putting more weight on one leg. So what happens? Wear and tear to that joint, your back, your disc, your knees. And so a lot of times the pain which comes from that is arthritic pain. And when it's in such a scenario, the standard arthritis medications which you use, like your doctors might give you like ibuprofen and Aleve, that's the kind of medicine that work best in them. Unless it's a more focused problem like a hip arthritis or a disc bulge, there many times your pain management or your orthopedic doctor will give you a shot of steroid and help reduce the inflammation. But depending on the scenario, Let's say you have a lot of pinched nerves. Your nerve is being pinched and you get radiating or shooting electric pain down your legs. Or you have neuropathy in your feet where the ends of your nerves in the bottom of your limbs are all damaged and they're constantly burning or tingling. Those kind of medicines are where you give certain seizure medications like gabapentin, Lyrica, certain mood medications like Cymbalta. These are all meds which you can use to kind of fool the nerves or the brain into thinking there is no pain signal being transferred. That's how those medicines work. Those medicines are not the standard run-of-the-mill over-the-counter pain meds which you take. Let's say you stub your toe, it hurts, you take a pain med or Tylenol, it goes away. These meds don't work like that. They're working more on the signal transmission in the nerve and the brain. So gabapentin can be useful in certain scenarios. So there's not one specific one for Parkinson's. There are certain medications which we use for Parkinson's which can also help pain itself indirectly. We have seen that with safinamide or Xadago is a medication which in the trials we had seen that incidentally all the patients who were taking Xadago, the high dose, 100 milligrams, had less pain. And so there are certain Parkinson's meds also which we can strategically use to kind of control their Parkinson's symptoms as well as help with pain too. So there are different strategies which we can use. Is it possible? Is hallucinations usually a late condition in Parkinson's? No, as I said, it can happen at any stage of the disease. From the very beginning of Parkinson's, you can develop hallucination. At that point, it's usually an offending medication. You took a dose and you took too much of it and bam, it just triggers a hallucination. Or in the middle stages of the disease where it's naturally damaging some of your circuits, which are involved in hallucinations, and they bring out natural hallucinations. That's what I'm talking about 7, 8, 9, 10 years into the disease. Or it can be in advanced Parkinson's where you've already developed dementia. With dementia and Parkinson's, one of the classic features of the dementia and Parkinson's is hallucinations. So not always is it a late finding which you see with dementia. It can be in the middle or even in the early stages. Is it possible to heal from psychosis? Meaning, I'm going to rephrase that, can your symptoms or hallucinations disappear entirely? Yes, especially in that early stages if you know that it is an offending medication which triggered it, or you know it's just a urinary tract infection or the dehydration which triggered it. Correcting those things usually corrects the hallucinations. But usually that middle to last stages of hallucinations, that's circuitry gone wrong. All right. How has Michael J. Fox lived for so long with Parkinson's? It's hard to say why people live longer or shorter with Parkinson's, but simply put, young onset Parkinson's patients live almost an entire lifespan with this disease. Sure, it's disabling, but their milestones are much more spread out. When people get it in their normal age range, which is late 50s or 60s, they start to develop these symptoms, they go the 15, 20 years. Regardless, at the end of Parkinson's, as you get to advanced Parkinson's, not the Parkinson's which actually gets you. It's all the disability which it gives you, which indirectly gives you problems which leads to death. For example, you are bed bound because you're not able to move well. You get bed sores, you get infections because a lot of time you aspirate your food or water and you get lung infections, you get recurrent infections. You fall, you break a bone or your hip, and that gets you into the hospital. So those are the kind of things which causes death in Parkinson's. And so if you're young and you're relatively well managed, you can live very long lives with Parkinson's. And I see that family support, well, I guess, attitude. These are all great things to have when you're living with Parkinson's, for sure. They all help you get by every day. I'm going to have cataract surgeries in a few weeks. Can you clarify what I should do regarding my Parkinson's? In general, what I meant by surgeries is that if you don't have any hallucinations or thinking issues, more often than not, such simple procedures, you do very well. You go in, you're done, you come out just fine. Some people who already have thinking decline, they already know they have thinking issues or they're on medicines for thinking, or they're already seeing those subtle hallucinations. That's already a red flag for you to know that if you get anesthesia or sedative meds or pain meds during surgery. When you come out of surgery, you're going to be more goofy than the other person who has a more intact brain, intact thinking. And so such patients will show a more prolonged stay in the hospital because they have to let all those medicines wear out and all its negative effect on your thinking clear up before you can be discharged. So many times we tell patients who already have thinking issues or hallucinations that, hey, if you're going in for a hospital stay, for whatever reason, any surgeries, etc., expect a little bit more of a prolonged stay in the hospital because you have to clear all those drugs out of your system in regards to your thinking. All right. I've had symptoms in my 30s. Pretty much, so somebody asked if they have young onset Parkinson's, that means you pretty much live your entire extent. It's not, as I said, the Parkinson's by itself that gets you. It is the end result disability. But in young onset Parkinson's, that disease is much more stretched out in terms of progression. Do you consider Parkinson's patients at a higher risk for COVID? Think of advanced Parkinson's patients at the higher risk profile, because advanced Parkinson's patients have very rigid trunk and body. So meaning their muscles are stiff and tight. They don't have great inspiration, expiration. They're also more prone to aspiration of fluids. So in general, they're more prone to bronchitis or aspiration pneumonia because of what goes wrongly in the wrong pipe. That's number one, which puts you, so if you get recurrent throat infections, lung infections, that lining is already inflamed and damaged. And so if you contract one more infection, it can be anything, it can be flu, it can be COVID, you're going to get a harder hit than the normal person. That's one. Number two, because their lung capacity is poor, because they can't expand very well, that too, it impacts how you recover from a bad case of pneumonia. So I would think more so it's in advanced Parkinson's patients that we think of. We've had some preliminary studies coming out from like Italy, which was one of the earlier hit countries, where they did not feel like there was a difference in how Parkinson's patients were affected with COVID.
Dr. K, thank you
Yes.
for sharing your expertise with us tonight and for fielding quite a few questions pretty expeditiously there. I want to remind you that next week on Tuesday and Thursday, we have Tuesday, there's a program that it's kind of like if you experience dizziness, it specifically kind of hones in on that. And then on Thursday, if you're curious about deep brain stimulation, Dr. Andrew Connor will be speaking on that next Thursday. And then we have a couple more weeks after that of programs. The mission of the Parkinson Foundation of Oklahoma is to inspire hope and transform life for Parkinson patients and families in Oklahoma. We want to equip you. There's lots of life to live with Parkinson's, and we want to help you live that life the best that you can. So to that end, thank you for being with us tonight. Dr. K, you can go ahead. We'll hang out as as everyone is being dismissed. But thank you so much for joining us tonight.